The shoulder is a marvel of human engineering, providing an incredible range of motion and serving as the connection point between the arm and the torso. In this video, we'll break down the muscles of the shoulder into clear functional groups, discuss their origins, insertions, and innervation, share mnemonics and memory aids tailored for USMLE preparation, cover clinical correlations to help you understand how this knowledge applies to real world cases. Let's get started. Overview of the shoulder muscles. The shoulder muscles can be categorized into three main groups. Intrinsic muscles of the shoulder. These muscles originate from the scapula or clavicle and insert on the humerus. They include the rotator cuff muscles and the deltoid. Extrinsic muscles of the shoulder. These muscles originate from the torso and attach to the scapula or humerus. These include the trapezius, latissimus dorsi, and others. Additional supportive muscles. Smaller muscles like the teres major play a supporting role. 1. Intrinsic muscles of the shoulder. O. The rotator cuff. The rotator cuff is a group of four muscles that stabilize the shoulder joint and allow rotational movements. Remember the mnemonic S is for the four rotator cuff muscles. Supraspinatus, infraspinatus, teres minor, subscapularis, supraspinatus, origin. Supraspinous fossa of the scapular insertion, greater tubercle of the humerus, action, abducts the arm, first 15 degrees innervation, suprascapular nerve, clinical correlation, supraspinatus tendinitis is a common cause of shoulder pain. Infraspinatus origin, infraspinous fossa of the scapular insertion, greater tubercle of the humerus, action, externally rotates the arm, innervation, suprascapular nerve, clinical correlation, weakness in external rotation suggests an infraspinatus injury. Teres minor, origin, lateral border of the scapula insertion, greater tubercle of the humerus, action, externally rotates and adducts the arm, innervation, axillary, nerve, tip. Think of the teres minor as the smaller sibling of the infraspinatus. Subscapularis, origin, subscapular fossa of the scapular insertion, lesser tubercle of the humerus, action, internally rotates the arm, innervation, upper and lower, subscapular nerve. Clinical correlation. Damage to this muscle can limit internal rotation, such as reaching behind your back. Deltoid. The deltoid is the powerhouse muscle of the shoulder. Origin, lateral clavicle, acromion, and spine of the scapula insertion. Deltoid, tuberosity of the humerus, action, anterior fibers, flexion and internal rotation, middle fibers, abduction, posterior fibers, extension and external rotation, innervation, axillary nerve, clinical correlation, axillary nerve injury, for example, after shoulder dislocation, can cause deltoid atrophy, resulting in a flattened shoulder contour. Transic muscles of the shoulder. First one is trapezius. Its origin is occipital bone, ligamentum nuchae, and spinous processes of C7 to T12. Insertion, lateral clavicle, acromion, and spine of the scapula. Its action is upper fibers, elevate the scapula, middle fibers, retract the scapula, lower fibers, depress the scapula. Innervation, accessory nerve, Cranial nerve 11. Do you know that damage to the accessory nerve can cause shoulder droop? Second one is latissimus dorsi. Its origin is spinous processes of T7 to L5, thoracolumbar fascia, iliac crest, and ribs 9 to 12. Insertion intertubercular sulcus of the humerus. Action extends, adducts, and internally rotates the arm. Innervation. Thoracodorsal nerve. Clinical correlation. Often used in flap surgeries due to its size and vascular supply. Let's move on to the third one, which is rhomboids. They are two in number. One is major and other one is minor. Origin spinous processes of C7 to T5. Insertion medial border of the scapula. Action retract and stabilize the scapula. Innervation dorsal scapular nerve. Levator scapula. Its origin is transverse processes of C1 to C4. Insertion medial border of the scapula, which is near the superior angle. Action it elevates the scapula. Innervation dorsal scapular nerve. Now we are moving to the additional supporting muscles. First one is teres major. Its origin is inferior angle of the scapula. Insertion medial lip of the intertubercular sulcus of the humerus. Action it internally rotates and adducts the arm. Innervation lower subscapular nerve. Second one is serratus anterior. Its origin is ribs 1 to 8. Insertion medial border of the scapula. Action protects the scapula and holds it against the thoracic wall. Innervation long thoracic nerve. Clinical correlation damage to the long thoracic nerve causes winging of the scapula. Clinical correlations and case studies. Understanding the shoulder muscles is not just about anatomy, it's about applying this knowledge clinically. Let's look at a case study to tie it all together. Case example. A 25-year-old patient presents with an inability to lift their arm above their head and noticeable scapular winging. What's the likely diagnosis? Answer: damage to the long thoracic nerve, leading to weakness of the serratus anterior. Such clinical reasoning is crucial for the USMLE, where you will need to connect anatomy to patient symptoms. Question of the day: which muscle is the main external rotator of the shoulder? Only a genius can answer in the comments below. If you would like to watch my other lectures on topics like the lungs, kidneys, liver, brain, and eyes, visit my channel to view my other videos.